Good. Got it. So we are recording our session about neuropathy. Neuropathy is interesting. I didn't have chance to get as much as I wanted to, but it still hopefully will be important and interesting information. And if we will not finish up now, we will continue at another time, because as said, I wanted to dig a little bit deeper there. So I wanted today to talk about what is neuropathy, what are the causes, and what can we do about that. So there are several types of neuropathy. If we look, neurological system consists of central system and peripheral system, and brain is our central system, and all kind of nerves that get out of the brain or get into the brain, those are peripheral nerves. And we have sensory nerves that allow us to feel different things, including touch, temperature, vibration, and that's our sensory nerves. Then we have motor nerves that allow us to move our body and know what is moving and what position your body is in. And then we have autonomic nervous system, which allows our regulation of internal processes. So for example, if you get up from sitting to standing position, your autonomic nervous system will allow the blood supply to stay the same into your brain, unless you're dehydrated. Then you can get up and you feel dizzy. And that could be the case with blood pressure medications, for example. And our heart has nerves that supply the heart and regulate the heart rate to some degree. And that's why you can play a joke on somebody and you can massage, for example, carotid bulb, which is on your neck, and massaging carotid bulb can slow down your heart rate, and actually to the point that people can pass out, not because of complete blood flow to the brain, but specifically because you're affecting the part of nervous system called parasympathetic. So for autonomic nerves, we have sympathetic that makes heart rate faster, and they will spasm your heart, spasm your arterial blood supply and will reduce blood supply. And parasympathetic, which is slows down the heart rate, helps the guts to work better, and will relax the blood vessels, will allow more blood flow. And it's different systems, therefore there are different nerves affected. And any parts of the nerves could be affected by different things. So what are the more common causes of neuropathy? Probably one of the most common ones will be diabetic neuropathy. And it's interesting, we'll talk a little bit more about that, but you could be pre-diabetic and already develop a neuropathy, and it probably depends on your nutritional status, B12 status, and many other things. Actual B12 deficiency can cause neuropathy too, and B12 is important not only for blood supply, but for function of the nerves, for detox, it helps our body to get rid of different toxins. And probably that is one of parts why people develop neuropathy, because our nerves, they are quite sensitive to toxins and to oxidative stress. Alcoholism, part of that because of nutritional deficiencies people develop with alcoholism. Then different medications, especially there are some chemotherapy agents that specifically side effect is known to be neuropathy. And unfortunately, because they work quite well for cancer treatment, people still have to use them. But as a result of that, they end up with neuropathy. Infections. Infections are very interesting. How one of the first conditions where people learned about neuropathy was leprosy. And leprosy is caused by a certain type of bacteria, which is relative of TB bacteria. And in the past, there were a lot of misunderstanding about leprosy, and therefore people were considered to be very contagious, and people would be put into leprosaries, so I don't know how you pronounce it, places where only people with leprosy lived. And leprosy affects nervous system tremendously, and people were losing sensation in their fingertips, in their feet, and everywhere else. And as a result, they would, for example, touch hot cup, and they would not feel that it's hot, and they could keep holding that cup. And as a result of that, they would have burns, and they can lose tips of fingers because of damage that the temperature was producing on the fingertips. And that is one of the conditions where we got tools for diagnosis of neuropathy. So shifting gears, other things, many of you probably have had shingles. Some of you may know that post-shingles neuropathy can cause a lot of pain. It can cause just numbness or tingling. It could be just not pleasant condition. And that's shingles. It's a zoster type of virus. Then Lyme disease is known to affect neurological system because Lyme spirochete frequently lives inside of nervous cells, nerve cells. Same as syphilis. We don't have as much syphilis, so I didn't put it here. But Lyme disease, there are more and more of it, and it can affect neurological systems and peripheral neuropathy and central nerves as well. COVID, more indications or more reports in the literature about the effect of COVID on nerves. And I have a slide about that as well. So amyloidosis is type of condition where special version of proteins will be collecting inside of cells, and it's poorly understood what triggers that. Frequently it will be some chronic conditions, chronic infections, and there is not much of good treatment, unfortunately. But those proteins that sit inside of the cell, they accumulate and they don't let nerve to work well. And that's amyloid type of protein as well is affecting people with Alzheimer. It's kind of same protein, just affecting different parts of the body. But in Alzheimer, it affects the brain. Then we could have paraneoplastic syndrome, which is people with different cancers may have specifically neuropathy related to those cancers way before the actual cancer shows up. So people with neuropathy, we want to think about that. And in people with neuropathy, try to look for all kinds of causes, possible causes. Then we have heavy metal toxicities. That's been long known back from, I don't know, 17th, 18th centuries, that people who are exposed to lead or arsenic or other versions of heavy metals would lose sensitivity in their hands and will get other symptoms of low dose toxicities. And obviously high dose can kill people, but low doses, people can live, but they just start losing their nerve system. Then there are some immune-mediated, like autoimmune versions of neuropathy. Then there are some inherited versions, which are fairly rare, so we're not talking about that. And there are some idiopathic, where you cannot find the cause, but apparently in those idiopathic, some people found to have certain genetic mutations that affect sodium channels, which hope in the future will allow in those idiopathic unknown cases figure out what actually causes the neuropathy and maybe start finding the treatment. So how do we diagnose neuropathy? This is diagnosis of sensory neuropathy. this 10-gram monofilament on top left is the tool that was originally designed to diagnose neuropathy and leprosy. And that's how we learned to do that in leprosy initially. But now, since we don't have leprosy that much anymore, you can use antibiotics to treat leprosy. We use the same tool for diabetics or pre-diabetics. You're supposed to use that at least once a year, more frequently if person has more advanced case. Usually endocrinology, primary care will do that. Of course, the podiatrist will do that. And it's actually fairly a rough estimation. If you lost this much of sensation, it means that your nerves is definitely affected. More sensitive tool is tuning fork on the right, and it has to be 128 hertz, not 10, not 250, but 128 hertz is the one which is passing through vibration sensory nerves. And that's the kind of tuning fork that we use in diagnosis of neuropathy in diabetics, or technically non in diabetics too. We can use that for any other version of neuropathy. The most sensitive tool though is EMG. And you can see the person arm. Usually with diabetics, we have feet that are affected more frequently than hands, but hands could be affected too. And EMG is a great tool to diagnose any other versions of nerve damages, peripheral neuropathies. It could be not only diabetic neuropathy, but it can be B12 deficiency, it can be other issues. And what we do there, you have small source of electrical signal, and you put small needles at different distances on arm and on legs, and anywhere where you want to establish diagnosis of neuropathy. And you send that electrical signal, and it travels from point A to point B to point C with certain speed. And you are going to detect that speed. And if the speed of conduction is normal, then there is no neuropathy. If the speed of conduction is affected at certain level, it can tell us that it may be the defect is actually starts right from the neck area, for example, or lower back area. If people have, for example, bulging disc, and the bulging disc is pushes on the nerve, then the whole nerve, on the whole length of the nerve from tip of the fingers up to the top of the arm will be affected, yes? If you have, for example, elbow issues, and elbow, that's where the damage to the nerve starts, then you will be able to determine that by having this, by conducting this electrical pulse. Or if you have small nerve issues, then you will have different part of the arm, like more distal arm, where you will see the damage to the nerves. So that's where the neuropathy, or that's how the peripheral sensory neuropathy is diagnosed. There are other tools for diagnosing of autonomic dysfunctions with the heart, with the stomach. And for stomach, usually it's gastroparesis, when stomach doesn't move fast enough, and people tend to have slow digestion to the point that like 24 hours later, you can still find remnants of food from day before. Usually, obviously, for that, you may need to have EGD, but there is actual tool where you can give barium, liquid barium, and check how fast. It's actually, they give egg. They mix barium, liquid barium with egg, and let you swallow that and see how fast stomach empties. So it's called stomach emptying study. And if it doesn't empty within between 2 and 4 hours, then it's a diagnostic for gastroparesis. Then there are some other tools related to blood pressure. There is a condition called POTS, postural orthostatic tachycardia, that frequently is autonomic dysfunction. And for that, particular dysfunction, we have to do tilt table test. You probably have heard about that, maybe not. It's pretty much you let person stand until one passes out. And normal person should be able to stand for a long time. But if you have autonomic dysfunction, then your blood starts pulling down and there is not enough blood supply to your brain, even if heart tries to squeeze fast. And if you have high heart rate, it's still not enough. And therefore people start passing out. And that's a frequently feature of posture orthostatic tachycardia. Not fun to have, but this test is the test that we use. Then there are some other tests for sweat, because sweating is part of autonomic dysfunction, and you can measure that, and there is temperature dysregulation, and people may have those too. And that's part of autonomic dysfunction. The only one other neuropathy, which is motor nerve dysfunction, that people get, that is pure physical examination. And here we will talk a little bit about that. So peripheral neuropathy, I guess it's probably the most common one I see, and that's why I put it here. And a lot of people have diabetes at this point, and a lot of people have pre-diabetes. And as I said, you may develop neuropathy even as pre-diabetic. But it gets worse if people have poor diabetes control, and it can get better when diabetes control improves. So the definition is presence of signs or symptoms of peripheral nerve dysfunction when other causes are excluded. And some people will have painful neuropathy. And if regular neuropathy is just numbness and tingling, for painful neuropathy, it will be burning, shooting pain. It could be muscle cramps. Allodynia is when if you touch your skin lightly, it causes pain. That is allodynia. That's why some people, when they come to me and they will say, you know what, when I go to sleep, I cannot let anything touch my feet. So they have to sleep with feet open because otherwise it's very painful. And it's very disabling because you cannot sleep well if you have any of those symptoms. And that's sensory neuropathy. For motor neuropathy, diabetics periodically develop foot drop. And occasionally people have like some facial eye droop. And some of those can be temporary, so they come and go. Some of them could be for the rest of the life. And obviously it's not fun. If you have foot droop, if you cannot lift your foot, that's a foot drop, then you will end up dragging your foot, and it increases chance of falling. And with peripheral neuropathy, people don't feel where they step frequently. I probably have mentioned this case to some of you. I had a patient who had severe neuropathy, and it's a woman, elderly woman who got new puppy. So she was sleeping, sitting with her legs down in a chair comfortably, and woke up at whatever in an hour or so, and she noticed that there was a puddle of blood on her foot. And that was first thing she noticed. And then she started looking, where's that blood coming from? And it was actually because her small puppy was chewing on her toe, and she didn't even know that because she had such a bad version of neuropathy that she had no sensation that puppy was chewing on the toe. So there is some of that. And in some severe case of neuropathy, people don't know where they stand, where they step on, and therefore we always suggest not to walk barefoot if you have any version of neuropathy, because you may step on some glass or something sharp and not know about that. And plus the other thing, we always suggest to look at your feet with a mirror, because it's hard to just twist your foot. So unless you have Ehlers-Danlos or some other version of hypermobility, it's probably hard to look at your feet. So therefore, it's best to have a mirror and put it on the ground and or whichever way you want, but to assess your feet daily, make sure there are no scrapes or anything like that. So it will help you prevent long-term issues. But unfortunately, some people don't do that, and they may end up with infection, which they may not notice right away. And they may end up with surgery. And with severe cases of neuropathy, people may not even need anesthesia because the neuropathy is so severe that they don't feel anything. And there is autonomic part for neuropathy. For diabetes, it's heart rate variability and gastroparesis and so on. So usually gastroparesis is quite challenging because when you eat, your stomach feels full and you cannot eat much, and stomach doesn't work, food doesn't passes through, and there is more constipation, and food doesn't get digested properly, and you are becoming more malnourished. And at the same time, people still don't lose that much weight, surprisingly, because you would think people would lose weight, but they still don't lose as much weight. But that's probably comes with diabetes and so on. And I didn't put any treatment for gastroparesis here, but I will mention that that there is a pacemaker for stomach that can be used, so stomach can start working better, kind of because it's triggered by that pacemaker. And for heart rate variability, if people develop low heart rate, here's a pacemaker for heart. So, and so next one, I wanted just to give a couple of things that I recommend for my patients with neuropathy. It's alpha lipoic acid. In study that actually I didn't put a citation for, but I will put, I think it's on the next page. It says that patients with diabetes up to 50% have this peripheral sensory motor neuropathy. The worsening will be with older age, longer duration of diabetes, poor diabetes control, increased cholesterol, and high blood pressure. And oxidative stress is always thought to be a pathogenesis of neuropathy, and including diabetic neuropathy. In diabetes, it's as well sugar attacks nerves and creates more of oxidative stress directly as additional risk factor. And alpha lipoic acid is one of very good antioxidative agents, and it shown to improve blood flow, reduce oxidative stress, improve distal nerve function in rat models, and technically in IV models for humans. So this particular study was to check if it will work in patients with oral version of alpha lipoic acid. In the study, they used 600 milligram. They did go to check different types of scores to see if it helps. And apparently it did help, and it helped not only with the pain and but with improvement of quality of life. And in general, they felt better. Guess what? Because diabetics frequently have oxidative stress all over, not only in the feet. If you take alpha lipoic acid, everything may start feeling better. And here, 50% of people actually had improved sense of well-being. Plus, there was improvement of triglycerides, even though weight, blood pressure, fasting sugar, all of that stayed the same. So that's why, based on this study and other studies, I do recommend 600 milligram of alpha lipoic acid, and I usually give it 300 twice a day. I personally take alpha lipoic acid periodically because it does feel it's frequently part of some detox, like liver detox. For me, I do take DIM detox, and I do notice that I do feel better with that. the alpha lipoic acid, when you take it, it makes your pee smell like asparagus. So if you kind of don't get scared if you try it, it's a totally normal reaction. So another medication that is shown to be proven to work for neuropathy is called Metanx. Here they had 214 people with neuropathy, and they found that there was not effect on vibration perception, meaning how much, how strong the vibration has to be in order to produce the sensation. But patients still reported symptomatic relief and improvement in different scores at week 16 and at week 24. I somehow missed number 4 there. And short form for SF36, it's pretty much quality of life. So technically, it looks like it helped not only with sense of pain, with neuropathic symptoms, but as well with well-being. And what is Metanx? Metanx is a combination of methylated folate at 3 milligram, methylated B12 vitamin at 2 milligram, and B6 at 35 milligrams. Based on this study, I use actually different product called Folinic Plus, usually because I like Folinic, and I do like methylfolate, but Folinic Plus is much cheaper than Metanx. But in some people, if Folinic doesn't work, I would switch to Metanx. Either way, I do see some improvements, and many people have subdeficiency of B12 or folate or B6, and that's why this combination of vitamins is probably the most commonly prescribed by us in our clinic, maybe after vitamin B6, because this, I'm sorry, vitamin D. Vitamin D is probably more common one that we prescribe, and after that comes Folinic Plus and Metanx. There were very infrequent side effects. I know some people with anxiety or depression may have a stronger reaction. They may not tolerate higher amounts of methylated folate and methylcobalamin at high enough doses. They may need to start a little bit on like half pill or half capsule and go up higher. But it's rare when people cannot. And even patients with MTHFR gene mutation will do really well with this because it has correct version of folate and correct version of B12. Regular cyanocobalamin, unfortunately, and regular folic acid, unfortunately, will not work for patients with MTHFR gene mutation. We do have a recording about genetics, and I spent some 20 minutes probably talking about that MTHFR gene mutation. So you can go back to Get Healthy and try to listen to that. Okay, so next. So this is very, very fresh study and very fresh approval. So FDA cleared this machine, it's neurostimulating device to treat neuropathic pain. And it was approved based on 63 patients with diabetes neuropathy, and they used it twice a week for 16 weeks. And interestingly enough, that pain was better not only for those 16 weeks, but up to 90 days. And I'll show you more about this device because they have like a minute and a half video and we can listen to that after I'll finish with the talk. So as I mentioned, COVID appeared to affect nerves, neurological system, and it could be central or it can be peripheral. And we talked last week about central effect because some people do end up with brain fog. It's definitely clearly effect on central nervous system, vasculature. And here we have peripheral systems, and including not necessarily totally peripheral system, but sense of smell, I bet, is effect on neurological system, obviously. But here, this particular study were 17 patients with long COVID. 10 of them, which is almost 60%, had tests that showed neuropathy, peripheral neuropathy. And they had actually not everybody had peripheral neuropathy. Some of them had muscle neuropathy, and 10 of them had small fiber neuropathy, which is similar to what we get with diabetes or B12 deficiency. And that caused chronic pain. Plus other symptoms were fatigue, weakness in muscles, change in their senses, pain in hands and feet. And for treatment, here they used corticosteroids as strong anti-inflammatory, intravenous immunoglobulins, which is immunological treatment to help to reduce, change pretty much immune response. And 5 people who received that immunoglobulin treatment had improved. Over time, 52% improved, but none had all of the symptoms go away. So it appears to be COVID is quite nasty, we know that. And this was fairly straightforward treatment without any functional medicine involvement. I would definitely try alpha lipoic acid in this category. I would definitely try to add glutathione, knowing that most likely it's, again, oxidative stress. And I would be curious to see if those research or studies will be conducted. So, okay, and this is all for right now, but let me stop sharing right now here, because I know I wanted to share screen to show you this. Let me see where it was. I think it's this one. No, it's not. I thought I was able to show you that. I don't know if you can see. Yeah, that can see. So this is the device. That's the device, neurostimulator for peripheral diabetic neuropathy. It sits apparently behind of the ear and delivers continuous pulses of low-level electrical current over 16 weeks, twice bi-weekly basis for 16 weeks. And after that, it apparently still had improvement. So the company is Diansys, or whatever, how you pronounce it. I tried to look for it. I couldn't find it. It's called First Relief. I couldn't find it on that company's website yet, but I bet it should become available soon enough. I'm not sure if it will be covered by insurance or whatever. Usually this type of device is not too expensive, so it shouldn't be that expensive, hopefully. Okay, good. So stop share. Okay, that's pretty much almost time to finish our discussion, but I would love to hear your what you think about what you've heard, any feedback, and was that helpful, not helpful, and so on. Don't be shy.
Well, I know I don't want to get neuropathy. Doesn't sound like any fun.
No,
I got it, and it's no fun at all.
yeah.
It was very helpful. I thought it was very helpful. I like the idea of just having some idea of what's going on whenever they're testing the neuropathy, because I have had the test for using the stick and the
Vibration.
Yeah, not the other thing. I haven't had the needles used yet. Is it reversible?
So some of that can be, but some of that could be far too gone. And it may not be reversible. Earlier you catch it, obviously better it is. But that's where, to me, electrical stimulation feels to me like will be something that will allow some reversibility, because it stimulates the nerves, and nerves possibly will start working and a little bit regenerating. So I think you need to combine things to get better. And I've seen some research about stem cells transplants, and transplantation for peripheral neuropathy apparently can be helpful and successful. I don't know if it would last for like the rest of your life, or the nerves will stop working later on. I don't remember that, but that could be interesting topic later on, because I know we talked about stem cells down at some point, but it was for different reasons. So I might be curious for me to look up about that.
I'm glad to understand it a little bit better. You know, when people talk about it, the one thing that I hear is that it from people is that it seems to get progressively worse over time.
Yes. And that's why if you don't do anything, it gets worse and worse, but that's where try to catch
But there's no reason not to try to do something. And so people shouldn't just sit there and do nothing.
Yep.
That's good to know.
Improving blood sugar control, trying this alpha lipoic acid. Usual medications are the gabapentin, and gabapentin could be really helpful. However, I know that people gain weight with gabapentin, and if we can avoid that and use some alpha lipoic acid or Metanx that do not cause that, I would do that as a first line. And if it doesn't work and you need gabapentin because it works more centrally, it doesn't affect your actual nerves, it just makes your brain not to react to the pain as much. So it's completely different mechanism. That's why I didn't even talk about regular treatments. Okay. Okay, very good. Thank you very much. I did try to send everybody text. I think next week is interstitial cystitis, and we will talk about the urine in general, what we find in urine on urinalysis, what are the crystals, what are the sediments, just so you know when you get your results, what that means. Okay.
Good. Thank you.
Okay.
And I will see whoever will want to come for the painting class. As I said, we'll have to change for second week, and we'll be drawing, or not drawing, painting the sunflower, which I sent to everybody. Hopefully it will come.
Let's see, that's supposed to be, wait a minute, I got it right.
Second. So this is the painting. I don't know if you
Oh, cool.
Very that, but yep. Good. And
It's so, oh, there it is. Okay, so that's the painting. That's cool.
so painting
And
number,
where does it say about the, oh, 9/9 at 6 p.m. And what day is that?
Friday. So always
Oh,
Friday.
it's just a different week. Okay, not different day of the week. It's just different week. Okay. All right,
Okay.
that sounds good.
Yep. Okay. See you all next week. Bye bye.
Thank you. Bye-bye.
Bye-bye.
Bye,
Bye.
Dr. Mulder.
Yep.
Thank you.